contributing to and improving infection prevention and control within the health and social care setting. By the end of this module, the learner should understand the term Standard Infection Control Precautions, SICP, have an awareness of the most common healthcare-associated infections, HCAI, be familiar with their organization's infection prevention and control policies and procedures and know where to access them, understand basic microbiology and routes of infection transmission, be able to discuss and demonstrate the standard infection prevention and control measures, including hand hygiene technique, wearing personal protective equipment, PPE, the management of blood and bodily fluid spillage, the management of occupational exposure, including sharps, the management of care equipment, be able to discuss and describe the 3 levels of decontamination, be able to conduct a risk assessment to ensure infection prevention and control measures are in place. Introduction infection prevention and control policies are at the heart of good clinical management and practice. However, they may vary between trusts and private settings. You must refer to and adopt the local policies applicable within your organization. Healthcare settings discussed in this module are: primary care settings include general practices, dental clinics, health centers, and polyclinics. This also includes care delivered by the ambulance service. Community care settings include residential homes, nursing homes, the patient's own home, schools and prisons, where NHS healthcare is provided or commissioned. What are healthcare-associated infections? The National Institute for Health and Care Excellence, NICE, defines healthcare-associated infections, HCAIs, as those infections that can develop either as a direct result of healthcare interventions such as medical or surgical treatment or from being in contact with a healthcare setting. The term HCAI covers a wide range of infections. The most well-known include those caused by methicillin-resistant Staphylococcus aureus, MRSA, methicillin-sensitive Staphylococcus aureus, MSSA, Clostridium difficile, C. difficile, and Escherichia coli, E. coli. HCAIs cover any infection contracted as a direct result of treatment in or contact with a health or social care setting as a result of healthcare delivered in the community, outside a healthcare setting, for example, in the community, and brought in by patients, staff or visitors and transmitted to others, for example, norovirus. HCAIs pose a severe risk to patients, staff and visitors. They can incur high costs for the NHS and cause significant morbidity to those infected. As a result, infection prevention and control are crucial priorities for the NHS. What causes healthcare-associated infections? Healthcare-associated infections are caused by different kinds of pathogenic microorganisms, infectious agents that can cause disease, including bacteria, viruses, fungi, protozoa, protists, ectoparasites. Many kinds of bacteria can cause infection. Many can be carried harmlessly in healthy people, known as colonization. However, for those individuals whose immune system is compromised or where the skin is breached, broken, bacteria can lead to infection. Certain kinds of bacteria will be associated with certain types of infection. For example, Escherichia coli, E. coli, usually lives in the intestines of humans and animals. Although most strains are harmless, other strains can cause diarrhea, urinary tract infections, respiratory illness, etc. Streptococcus pneumoniae can cause many types of infections, including pneumonia, lung infection, meningitis, and infection of the lining of the brain and spinal cord. Group hemolytic streptococci can cause a range of infections, from mild to severe, deadly diseases, including strep throat, throat infection, cellulitis, infection of the skin that causes redness, swelling and pain, scarlet fever, a mild condition that causes a sore throat and a red rash that can spread over the body, impetigo, a mild infection that can occur anywhere on the body. It most often affects exposed skin, such as around the nose and mouth or on the arms or legs, and necrotizing fasciitis, a rare but potentially life-threatening bacterial infection that affects the tissue beneath the skin and surrounding muscles and organs, fascia. Viruses. Viral diseases are prevalent infections caused by viruses, a type of microorganism. There are many types of viruses that cause many viral diseases. The most common type of viral disease is the common cold, caused by a viral infection of the upper respiratory tract, nose and throat. Other common viral diseases include chickenpox, flu, influenza, human immunodeficiency virus, HIV, AIDS, mumps, measles and rubella, shingles, viral gastroenteritis, stomach flu, viral hepatitis, viral meningitis, viral pneumonia. Fungal infections, mycosis, are skin diseases caused by fungus. Although most fungi are harmless to humans, some of them can cause diseases under specific conditions, including asthma or allergies. Rashes are infections on the skin and nails, lung infections, pneumonia, with symptoms like the flu or tuberculosis, bloodstream infections, meningitis. Protozoa are microscopic, one-celled organisms that can be free-living or parasitic in nature. They can multiply in humans, which contributes to their survival and also permits serious infections to develop from just a single organism, CDC, 2022. Common protozoal infectious diseases include malaria, a mosquito-borne infectious disease caused by Plasmodium parasites that affects humans and other animals. Malaria can be a life-threatening disease transmitted to people through the bites of infected female Anopheles mosquitoes. It is preventable and curable. Giardia, a tiny parasite, germ, that causes the diarrheal disease giardiasis. Giardia is found on surfaces or in soil, food, or water that has been contaminated with feces from infected people or animals. Toxoplasmosis, an infection caused by a single-cell parasite called Toxoplasma gondii. Symptoms of toxoplasmosis may include swollen lymph glands, muscle aches and pains, headache, fever, and inflammation of major organs. Can HCAI infections be treated with antibiotics? Most infections caused by bacteria can be treated with common antibiotics. Some are resistant to antibiotic treatment. MRSA, methicillin-resistant Staphylococcus aureus, C. diff, Clostridium difficile, VRE, vancomycin-resistant enterococci, MDR-TB, multi-drug-resistant tuberculosis, MCP, carbapenemase-producing enterobacteriaceae are just some examples of drug-resistant microorganisms that can limit the treatment options for sometimes very ill patients. Infections that are caused by viruses, for example, the winter vomiting disease caused by the norovirus, cannot be treated by antibiotics and can spread very quickly if they are not controlled. As a healthcare worker, student, you are accountable and responsible for the continuous quality improvement in relation to infection prevention and control and adhering to your organization's policies and procedures. There are 10 elements of SICPs. 1. Patient placement, assessment for infection risk. 2. Hand hygiene. 3. Respiratory and cough hygiene. 4. Personal protective equipment, PPE. 5. Safe management of care equipment. 6. Safe management of the care environment. 7. Safe management of linen. 8. Safe management of blood and body fluids. 9. Safe disposal of waste, including sharps. 10. Occupational safety, managing prevention of exposure, including sharps. Healthcare-associated infections, standard infection control precautions, SICP, National Hand Hygiene and Personal Protective Equipment Policy, NHS England and NHS Improvement, 2019, Standard Infection Control Precautions, SICP, are designed to prevent cross-contamination from recognized and unrecognized sources of infection. These sources of potential infection include blood, droplets through expiration, sneezing, coughing, and other body fluid secretions or excretions, and through the use of equipment or items in the care environment which are likely to become contaminated. SICPs are to be used by all staff, including students and temporary agency workers, in all care settings, at all times, for all patients whether infection is known to be present or not, to ensure the safety of those being cared for, staff and visitors in the care environment. The application of SICPs during care delivery is determined by assessing risk to and from individuals. This includes the task, level of interaction and/or the anticipated level of exposure to blood and/or other body fluids. To protect effectively against infection risks, SICPs must be used consistently by all staff. SICP's implementation monitoring must also be ongoing to ensure compliance with safe practices and to demonstrate ongoing commitment to patient, staff, and visitor safety. Everyone involved in providing care should be educated about the standard principles of infection prevention and control and trained in hand decontamination, the use of personal protective equipment, and the safe use and disposal of sharps. Alert organisms and condition surveillance. Alert organisms are those identified as posing a public health risk to patients, staff, and visitors defined by the Department of Health, BH 1995. The key alert organisms for communicable diseases include all the diseases notifiable under the public health legislation, including MRSA, respiratory infection, C. difficile outbreaks, transmissible spongiform encephalopathies, as well as several others of public health significance, including Legionella, E. coli 157, Creutzfeldt-Jakob disease, CJD, whilst is the responsibility of the medical microbiologist for informing clinical teams when a new clinical isolate, i.e. not screening specimens, of an alert organism has been identified. All employee and healthcare personnel are required to ensure that they undertake relevant IPC training available to them, adhere to all trust policies and protocols applicable to IPC, ensure they are aware of the plan for managing the HCAI and complete all relevant documentation as required, ensure that they utilize safe working practices as outlined in IPC policies and procedures, report to the IPCT at the earliest opportunity an infection that may be deemed infectious to others. Advice on the control measures, if needed, will usually be provided by the Infection Prevention Team, IPC, who will also investigate clusters of cases. However, it is still the responsibility of the clinical team to access and follow up any microbiology results for their patients. All employees who are seconded to NHCT, all bank and agency staff together with any contractors employed by the Trust will be personally accountable for their actions and are responsible for ensuring that they comply with IPC policies and procedures. Public Health England undertakes ongoing surveillance of all key alert organisms as well as other organisms including all healthcare-associated infections from the community and acute hospital trusts. The aim of this surveillance is to monitor trends and identify outbreaks to enable prompt action to be undertaken. Data on all key alert organisms is collected from clinicians and laboratories on a routine basis in accordance with national legislation relating to notifiable diseases and agreed arrangements around reporting between PHE and laboratories. Where there is an outbreak of an alert condition, the health and social care providers, particularly those who offer residential care, need to have appropriate procedures to control the spread of the infection. These may include providing isolation facilities, identifying potential sources of infection using the appropriate protective measures and equipment, using additional protective measures and equipment as specified by the Infection Prevention and Control Team. METICILLIN resistant Staphylococcus aureus, MRSA. Staphylococcus aureus is a bacterium that can reside on the skin and is found in the nose of about 1/3 of healthy individuals. Methicillin-resistant strains of Staphylococcus aureus are known as MRSA. Although MRSA is much less common than the normal methicillin-sensitive strains of S. aureus, MSSA, they are more likely to be found in healthcare settings. MRSA is resistant to all beta-lactam antibiotics, penicillins, cephalosporins, and is frequently resistant to other antibiotic classes. Over the last 25 years, MRSA has become endemic in many acute hospitals in the UK. When MRSA is isolated on the skin or nose, this does not necessarily mean that the person will develop an infection. Such patients, who carry the organism but are not clinically infected, are termed colonized. It is important to understand the difference between colonization and infection with MRSA. MRSA can cause disease if there is an opportunity for it to enter the body through broken skin or a procedure requiring the use of an invasive medical device, HPA 2013. If the bacteria enter the body, mild to life-threatening illnesses may then develop. These include skin and wound infections, infected eczema, abscesses or joint infections, and pneumonia. It also has the potential to induce infection of the bone, osteomyelitis, infections of the heart valves, endocarditis, and bacteremia, bloodstream infection, leading to infections in any of the major organs of the body, HPA 2013, WHO 2013. S. aureus is also responsible for many serious community and hospital-acquired infections, being the most frequently isolated bacterial pathogen from patients with hospital-acquired infections, especially those with implants or prosthetic devices, WHO 2013. Patients with MRSA will be either colonized or infected. Colonization of the bacteria occurs on the skin, in folds of the skin, nose, perineum, and umbilicus. It can also colonize in leg ulcers and chronic wounds but does not cause infection, and most individuals are asymptomatic and otherwise well. Where the bacteria penetrates and enters the body and multiplies into the tissues, this is known as MRSA infection. Typical signs and symptoms include inflammation, erythema, high temperature, pus, exudate from wounds and pain, indicating medical intervention and appropriate antibiotic therapy to be administered. At-risk groups MRSA can exist harmlessly as previously discussed. However, there are groups of individuals who are considered at increased risk of MRSA infection: neonatal, premature babies, immune-compromised patients, elderly, those being treated with intravenous medication, fluids, catheters in situ and other invasive devices including PEG tubes, tracheostomies, etc., diabetics, those with chronic wounds, residents in nursing, residential homes, individuals undergoing surgery. Transmission MRSA can be transmitted in numerous ways including OHAN's direct contact with patients and the immediate environment. This is thought to be the primary transmission source of MRSA cross-infection. Skin conditions where skin cells shed such as dermatitis, eczema, psoriasis, etc. Equipment inadequately disinfected hospital equipment such as drip stands, monitors, infusion pumps, commodes, bedpans, moving and handling equipment, etc. Airborne MRSA present in sputum can be passed through coughing or expectorating. Management of MRSA: in the event an inpatient is diagnosed with isolated MRSA, the ward will be contacted by either a microbiology doctor or an infection prevention and control nurse, IPCN. Over the weekend period, the microbiologist on call will inform and advise the MRSA protocol clinical site manager of the new MRSA positive patients. It is responsibility of the clinical site manager to inform the nurse in charge of the appropriate wards, clinical areas of the new MRSA positive results, and the isolation plans. Communication is vital regarding effective management of MRSA and must be included in the patient's notes for all healthcare providers to access and be notified. It is the responsibility of all staff to inform the patient and provide them with an information leaflet. The IPCN can be contacted if further detailed advice is required. It is the responsibility of the nurse in charge and the ward doctor to inform other members of the multidisciplinary team involved in the care of the patient, e.g. nurses, doctors, therapists, and students. Hands must be washed or decontaminated before and after every patient contact, in conjunction with the 5 moments for hand hygiene, including between patients in MRSA cohorts. Personal protective equipment, PPE, clothing must be worn by all staff for each patient episode as per isolation precautions protocol. Long hair must be tied back, sleeves must be rolled up, wristwatches and jewelry, except one plain band ring, removed as per local policy. After contact with a patient or their surrounding environment, gloves and apron must be removed whilst in the room, disposed of in a yellow clinical waste bin and hands decontaminated before leaving the room. Ensure that the general environment is kept clean and maintained, including soft furnishings and linen. Linen should be handled with care to prevent excess dust, particles being created. Clostridium difficile. Clostridium difficile is another important HCAI and is recognized as a major cause of diarrhea, runny stools, affecting patients in hospital, care or residential homes, and primarily those over the age of 65 years of age. Clostridium difficile can cause outbreaks in wards which can lead to closures, and has a significant impact on the dignity of patients due to foul smelling, fecal incontinence which can last for several days. Clostridium difficile, also known as C. difficile in some clinical areas, is a significant spore-forming organism in the health and social care setting, where the infection most commonly affects people who have recently been treated with antibiotics, but it can spread easily to others. C. difficile infections are unpleasant and can sometimes cause serious bowel problems, but they can usually be successfully treated with another course of antibiotics such as metronidazole, Flagyl, and fidaxomicin, difficid. Key facts: Clostridium difficile is anaerobic bacterium, which means it can survive in oxygen-free environments. Clostridium difficile produces spores that are resistant to most disinfectants, can survive in the correct environment for many months. The toxins produced by the spores are the causes of the diarrhea symptoms. The illness can range from mild, self-limiting diarrhea to severe, potentially fatal pseudomembranous colitis. Symptoms may include frequent episodes of watery, green, foul-smelling diarrhea a day and also present with fever, abdominal cramps and occasionally blood in the stools. Complications can arise such as dehydration, electrolyte imbalance and perforation of the colon. Infections can be triggered with use of certain antibiotics and cephalosporins such as sfotaxine. Infection is spread through the fecal-oral route where spores can contaminate the patient's skin and hands and then to the healthcare worker and surrounding environment. Management of Clostridium difficile. Should you suspect a patient to have Clostridium difficile, ensure that appropriate investigations including stool sample are undertaken, and keep them in isolation away from other patients, if possible, such as in a single-side room. Diagnosis of Clostridium difficile is confirmed from toxin-positive stool samples sent to the laboratory. Where a patient has been confirmed to be infected, all pre-existing antibiotic therapy must be stopped and further review is required to ensure the appropriate treatment can be given. Seek advice from your local infection control team and microbiologist on site and refer to your local policies. Ensure the patient has their own commode and ensure they are cleaned after each use with neutral detergent and water and disinfected using a chlorine-based agent. Promote and ensure thorough hand washing techniques is performed by your patient, staff with contact with the patient and their visitors. Note that alcohol gel is less effective for Clostridium difficile spores and should be avoided after using soap and water. Ensure you wear protective clothing when in direct contact with the infected patient, including single-use gloves and aprons. This included changing bed sheets and cleaning room as well as handling blood and bodily fluids. All patient care equipment must be decontaminated before it is transferred to another patient. Ensure the vacated bed space is thoroughly cleaned as well as meticulous cleaning of surrounding soft furnishings such as drapes, curtains. Refer to local policies. Communication is paramount and an explanation should be provided to the patient and their visitors, whilst still preserving the dignity and confidentiality. All staff and healthcare providers managing the patient must be informed to ensure they take the necessary precautionary measures to reduce spread of infection. Viral gastroenteritis can be caused by a number of viruses including norovirus and rotavirus. Viral gastroenteritis is an illness caused by a number of viruses including norovirus or rotavirus. Gastroenteritis means inflammation of the stomach, small and large intestines. The viruses cause various symptoms which may include diarrhea, often watery, nausea and vomiting, often violent and sudden, stomach cramps, headache, fever, malaise, general feeling of being unwell. The viruses are spread, O from contact with other people who have viral gastroenteritis, O from food contaminated by someone who has viral gastroenteritis, O from raw food or uncooked food, particularly meat and fish. The viruses are highly contagious and can be easily spread within hospital wards, mental health units, schools, nurseries and institutional settings such as nursing and residential homes. Gastroenteritis will usually clear up in 2 to 4 days when the infection has cleared. However, you should not return to work until 48 hours have passed since your last episode of diarrhea and/or vomiting. Blood-borne viruses hepatitis B, HBV, and hepatitis C, HCV, are viral infections that attack the liver and can lead to serious liver disease. Human immunodeficiency virus, HIV, is viral infection that attacks the body's natural defense mechanisms, your immunity to disease. They are present in blood and other body fluids. As a healthcare worker, some of the healthcare activities you do will carry the risk of exposure to blood-borne viruses. The 3 types of exposure in healthcare settings where there is known to be significant risk are percutaneous injury, e.g. from needles, instruments, human bites, O exposure of broken skin, e.g. abrasions, cuts, active eczema, O exposure of mucous membranes, including the eye, mouth and gums. You can reduce your risk by handling sharps safely, wearing face protection if there is a risk of splashing, keeping fresh cuts and grazes covered with a waterproof plaster, reporting an incident or sharps injury as described above promptly to your manager or occupational health, vaccination against hepatitis B vaccination. There are currently no vaccinations for immunization against hepatitis C or HIV. Disposing of sharps and handling sharps injuries, and personal protective equipment, PPE, handling blood and body fluid spillage safely. The chain of infection can only spread when the conditions are right. We call this set of conditions the chain of infection. Think of the conditions as links in a chain. When all the links are connected, infection spreads. All infection control processes and procedures should aim to break the chain of infection. Breaking the chain of infection at any point stops infection from spreading, but efforts must be made to always aim to break the chain of infection as early as possible. Infection prevention and control. Infection prevention and control everyone responsibility, and it is not something you should do only if you have time. It is something you need to consistently do in and outside the workplace. In order to create an effective infection prevention and control process, you must be able to identify what the correct processes are which make up the standard precautions and report all concerns or observations. What can you do? Examples of actual risks that you should look out for and report to the responsible person, teamer. Used needles lying around which may cause injury to you or others. Staff not adhering to hand hygiene procedures. Visibly soiled shared equipment such as chairs, commodes, beds, etc. Staff wearing disposable aprons and gloves unnecessarily. Staff wearing watches or jewelry with stones, sharps containers. Closure device left wide open when not in use where there is a risk of others putting their hands in and injure themselves. Staff coming into work with signs and or symptoms of infections. Storage areas are overstocked or not being regularly cleaned. Staff who fail to adhere to local infection control policies and procedures. Soap dispensers and or hand sanitizer units needing replenished. If you are unsure about infection prevention and control processes in your current place of work or have concerns, the following specialist teams and colleagues can support you. O Senior Nurse, O Infection Prevention and Control Team, O Cleanliness Champion, O Occupational Health Staff Member, O Health Protection Team. Infection Prevention and Control Risk Assessment. What is Infection Control Risk Assessment? An infection control risk assessment is more than just running down a list of potential hazards and informing personnel of best practices. A sophisticated infection control risk assessment is a living document that forms the foundation of any comprehensive IPC program. An infection risk assessment considers potential hazards and prioritizes them to better guide goal setting and strategy development. Infection control risks can stem from a variety of areas in a healthcare organization, and most can lead to significant patient or staff harm. Some common examples include lack of hand hygiene, unsafe injection practices, poor cleaning, disinfection, sterilization of instruments and scopes, inadequate environmental cleaning. To understand which risks pose the greatest threats to your facility, you must assess your current operations. How to assess the risks or identify the hazards, e.g. bloodborne viruses, gastrointestinal infection. O decide who might be harmed and how. O evaluate the risks and decide on precautions. O record the findings and implement them. O review the assessment and update if necessary. Personal Fitness to Work Immunizations Against Communicable Diseases. The Health and Safety at Work Act, HSWA, 1974 imposes a legal duty of care on all employers, employees, agency workers, students, voluntary staff and the self-employed working in the healthcare sector to protect, so far as reasonably practicable, those at work and others who may be affected by their work activity, including contractors, visitors and patients, service users. Any potential risk of communicable disease being transmitted to vulnerable or susceptible service users require to be reduced to an absolute minimum, and as an HCW, this would be to ensure you are vaccinated against vaccine-preventable infections including hepatitis B, tuberculosis, measles, mumps, rubella and varicella. Immunization of healthcare and laboratory staff. Any vaccine-preventable disease that is transmissible from person to person poses a risk to both healthcare professionals and their patients. Healthcare workers have a duty of care towards their patients, which includes taking reasonable precautions to protect them from communicable diseases. Immunization of healthcare and laboratory workers may therefore protect the individual and their family from an occupationally acquired infection, protect patients and service users, including vulnerable patients who may not respond well to their own immunization, protect other healthcare and laboratory staff, allow for the efficient running of services without disruption. If you are not up to date with your immunizations, you must seek review with your occupational health department or primary healthcare provider. And hygiene. 2 ways to decontaminate your hands. Hand hygiene is one of the most important procedures that all staff should be implementing to promote infection control and prevention. Our hands carry 2 different types of organisms, these being transient and resident. Transient organisms may be picked up by healthcare staff following contact with patients or surrounding environment. Due to the antibacterial properties of the skin on our hands, the bacteria can live for a few hours, of which there is a risk of transmission during this time to others. Effective hand washing after any contact can minimize this risk of transmission. Microorganisms that are difficult to remove as they settle in the crevices of skin folds, hair follicles and sweat glands. The removal of resident microorganisms is only necessary prior to invasive procedures such as surgery and require the use of antimicrobial soaps such as triclosan and chlorhexidine. To ensure compliance with hand hygiene, all healthcare workers must keep nails short, clean and polish-free. Do not wear artificial nails or nail extensions. Avoid wearing wristwatches and jewelry. Avoid wearing rings with ridges or stones. A plain wedding band is usually acceptable, but check your local organization's policy. Cover any cuts and abrasions with a waterproof dressing. Wear short sleeves clothes or roll-up sleeves, bare below the elbow, and comply with local dress code or uniform policy. Report any skin conditions affecting hands for, e.g. psoriasis or dermatitis, to the nurse in charge when on an assignment, or the client relations team. There are 2 ways you can decontaminate your hands: O liquid soap and water, hand washing, O alcohol-based hand rub. 13 steps in the process of achieving optimum hand hygiene. Hand washing: use warm running water, wet the hands before applying soap, apply enough soap to cover all hand surfaces, rub hands palm to palm, rub back of each hand with palm of other hand with fingers interlaced, rub palm to palm with fingers interlaced, rub with back of fingers of opposing palms with fingers interlocked, rub each thumb clasped in opposite hand using a rotational movement, rub tips of fingers in opposite palm in a circular motion, rinse hands with water, rinse well with the hands uppermost so that the water runs off the elbow. O user, hands free, e.g. elbows, technique to turn off taps. Where hands free tap systems are not in place, dry the hands first with paper towels and use these to turn off the tap. So dry each part of the hands properly and dispose of paper towels in the appropriate waste bin without recontaminating your hands, e.g. use the foot pedal. Do not touch the bin lids. Hand washing should take 15 to 30 seconds. Alcohol-based hand rub is useful when sinks for hand washing are not readily available or when hands may be contaminated, but not visibly soiled, e.g. entering or leaving a ward, clinical, patient area, is not effective if hands are soiled, as organic matter can inactivate the activity of alcohol, is not effective against spore-forming organisms, e.g. Clostridium difficile, or norovirus, can also be used following hand washing to provide a further cleansing and residual effect. Steps to perform hand hygiene using alcohol-based hand rub are the same as when performing hand washing. Hand hygiene with alcohol rub should take 15 to 30 seconds. The amount, volume to provide adequate coverage of the hands should be indicated in the manufacturer's instructions, but is normally around 3 ml. It must be remembered that alcohol is not a cleaning agent and will not be effective in the presence of physical dirt. Hands must be physically clean before alcohol is applied. Aseptic technique. Aseptic technique is required whenever you are carrying out a procedure that involves contact with a part of the body or an invasive device where introducing microorganisms may increase the risk of infection. The principal aim of an aseptic technique is to protect the patient from contamination by pathogenic organisms during medical and nursing procedures. In healthcare settings, it means that any part of a device or other equipment that will come into contact with a susceptible site on a patient remains sterile, and where all staff undertaking aseptic procedures adhere to local hand hygiene policies ensuring that they are bare below the elbow. Aseptic non-touch technique, ANTT. Aseptic non-touch technique, ANTT, is the practice of avoiding contamination by not touching key elements such as the tip of a needle, the seal of an intravenous connector after it has been decontaminated, or the inside surface of a sterile dressing where it will be in contact with the wound. This means avoiding contact with sterile equipment that will be used invasively, e.g., the tip of a needle or hub of cannula, sterile products used for preparing solutions for injection, e.g., the hub of the syringe or tip of a needle, the surface of a sterile dressing that will be in contact with the wound, seals of IV connectors that have been disinfected prior to administration of medication, skin after it has been disinfected prior to phlebotomy or cannulation, open wounds and invasive device sites. All clinical staff are responsible for ensuring that they understand the principles of aseptic technique and can apply them to practice competently. Personal Protective Equipment Regulations 1992, PPE. PPE is defined by the HSE as equipment that will protect the user against health or safety risks at work. It can include items such as safety helmets, gloves, eye protection, high visibility clothing, safety footwear and safety harnesses. It also includes respiratory protective equipment, RPE, and should only be used as a last resort. What the law states, under the Health and Safety at Work Act, 1974, and Control of Substances Hazardous to Health, COSHH, regulations, employers, including the NHS, are expected to identify and control hazards. Such hazards include exposure to potentially pathogenic microorganisms in blood, body fluids, excretions and secretions, non-intact skin and mucous membranes. All healthcare staff must wear PPE as necessary to avoid exposure to blood, bodily fluids, secretions and excretions and contamination of clothing. The selection of PPE must be based on assessment of the risk of transmission of microorganisms to the patient and/or the healthcare worker. For low risk, you will need gloves. There are two main types of gloves, sterile and non-sterile, both of which are for single use, are not a substitute for good hand hygiene, which must be performed before donning gloves, immediately after the removal and disposal of gloves, and between every change of gloves. Should be well-fitting and comfortable, must be worn for invasive procedures, contact with sterile sites and non-intact skin or mucous membranes, and all activities that have been assessed as carrying a risk of exposure to blood, body fluids, secretions and excretions, must be worn when handling sharp or contaminated instruments. This includes venipuncture, cleaning spillages, etc., should be put on immediately before patient contact, treatment and removed as soon as the activity is completed. Prior to starting work, staff must cover all cuts and abrasions with a waterproof plaster, must never be cleaned with products such as alcohol-based hand rub. An apron. The most common type of apron is the standard plastic apron. Clean plastic aprons are adequate for most clinical and non-clinical activities. Like gloves, they are for single use. Should never be worn whilst moving to a different patient, client, area. Aprons may be color-coded for specific tasks and/or in specific areas according to local policy, e.g. when handling or serving food within a clinical area. If there is a risk of significant splashing of blood, body fluids, secretions or excretions, a full body fluid repellent gown should be worn to prevent contamination. When removing a gown, apron, the outer contaminated side should be turned inward, rolled into a ball and discarded immediately as clinical waste where there is a high risk of splashing. In addition to gloves and an apron, you will need a mask or eye protection. Face, mouth and eye protection, surgical masks, goggles and face shields, visors, must be worn where there is a risk of blood, body fluids, secretions or excretions splashing into the face and eyes. Manufacturer's instructions should be adhered to while donning face protection to ensure the most appropriate fit, protection. Surgical masks should always fit comfortably, covering the mouth and nose. When not in use for protection, they should be removed and not worn around the neck. Goggles should provide adequate protection when the risk of splashing is present, e.g. those used must wrap around the eye area to ensure side areas are protected. Face shields, visors should be considered, in place of a surgical mask and/or goggles, where there is a higher risk of spattering, aerosolization of blood, other body fluids. Face protection should not be touched while being worn and should be removed immediately following a procedure. Surgical masks must be changed if they are wet or soiled. Efficacy of surgical masks in providing protection against airborne droplet infections is the subject of continuing debate, as is the length of time they can be worn for. The use of specialist filtering facepiece, FFP3, masks is sometimes necessary to protect yourself against serious respiratory infections including active tuberculosis and SARS. FFP3 cover the mouth and nose, and prevent air from passing in from around the edges. Instead, air passes through the fabric which acts as a filter. If you need to wear these masks, it is essential that the mask fits correctly and is tested to ensure it fits properly, as it may not be suitable for certain healthcare workers, for example, those with facial hair. Sharps disposal, sharps, and needles, blades, such as scalpels, and other medical instruments that are necessary for carrying out healthcare work and could cause an injury by cutting or pricking the skin. Clinical staff are responsible for the correct disposal of sharps so that the safety of non-clinical staff who remove the sharps bins is not put at risk. Small sharps bins can be taken to the point of use, e.g. the patient's bedside, to enable immediate disposal. Needles should never be resheathed and sharps bins should not be overfilled. Sharps containers must be labeled with point of origin, be signed and dated as to who put the container, bin together, never be overfilled, replace once 3/4 full, taken to point of use, have a securely fitting lid, be secured out of public reach and access, not to be disposed of in clinical waste bag. Management of exposure to blood and body fluid spillage. Accidental exposure. Accidental exposure is defined as all penetration with used sharps, needles, percutaneous, contamination of abrasions, cuts, grazes, broken skin with bodily fluids, splashes of bodily fluids, aerosols to the eyes, mouth or nose, mucocutaneous. If your skin is pricked with a sharp item or you have been involved in an accidental exposure to bodily fluids, it is essential that first aid is carried out quickly. In the event of a sharps injury or exposure to bodily fluid, splash injury, you should encourage the wound to bleed under running water. Do not scrub or suck the area. Wash, irrigate with soap and warm running water. Do not use disinfectants or alcohol. Dry the area and cover the area using a waterproof dressing. If exposure is to eyes or mouth, areas should be rinsed, irrigated with copious amounts of water. Mouth washout kits may be available in clinical areas. Do not swallow the water that has been used for mouth rinsing following mucocutaneous exposure. If contact lenses are worn, irrigation should be performed before and after removing these. Do not replace the contact lens. Report the incident. Immediately report, document the incident following local reporting procedures. If you are unable to contact occupational health or the incident has happened out of hours, go to your nearest accident and emergency department and tell them what has happened. Certain exposures to bloodborne pathogens must be reported to the Health and Safety Executive under the Reporting of Injuries, Diseases and Dangerous Occurrences Regulations 2013, RIDOR. All accidental exposures must be reported to the HSE when an employee is injured by a sharp known to be contaminated with a bloodborne virus, BBV, e.g. hepatitis B or C or HIV. The employee acquires a BBV infection as a result of a sharps injury. This is reportable as a disease. The employee is absent from work for over 7 days. Blood or bodily fluid spillages. Any blood or bodily fluid spillage must be dealt with immediately. Blood spill. Most carpets and soft furnishings cannot sustain a chlorine-releasing agent. Appropriate PPE must be worn. Cover the spill with disposable paper towels. Gently pour chlorine-releasing agent, 10,000 ppm, over the paper towels. If granules available, pour the granules over the spill, leave 2 to 5 minutes, scoop residue and put into an orange clinical waste bin. Handling specimens. When transporting specimens to and from departments, always take special care in handling same and ensure the correct container is used. All clinical details including patient's ID, date of birth, ward, etc. are clearly seen on the container. Samples reach the designated laboratory in the quickest, safest and approved route. Any specimens that are required to be posted to a designated lab that you obtain appropriate advice from infection control team, especially if the samples are from patients with known or suspected bloodborne viruses, and containers must also be labeled with danger of infection. Store any specimen samples in a designated specimen fridge only. Laundry. Ensure all soiled or stained laundry is appropriate, bagged from point of removing from bed, etc. Soiled bed linen must be placed into a red biodegradable, water-soluble bag, and gloves and apron must be worn at all times. Always seek advice from infection control team regarding the laundering process. In clinical areas where there is an infection outbreak, there should be plenty of bags available to take all used linen. The bags should not be too full, as this increases the chance of laundry staff having direct contact with the dirty linen. There should be a safe collection point that all staff know about. All linen bags should be tied properly to avoid unnecessary handling. Waste that is not handled correctly can pollute the environment and present a risk to people. Please ensure you follow your organization's guidelines for waste disposal. All waste is segregated into different types and clearly labeled. All waste must be safely handled, collected, stored, transported and disposed of in line with regulations. If waste is spilled, then the correct action must be taken to make the area safe. Summary. Good infection prevention and control practices can substantially reduce healthcare-associated infection. Every year, more than 300,000 people contract an infection associated with healthcare. Therefore, effective prevention and control of infection must be part of everyday practice and consistently applied by everyone. All staff play an important part in the control of infection. Staff should read and apply the principles and practices in the guidance to demonstrate commitment to high-quality care and patient safety.